President Cyril Ramaphosa has increased the lockdown regulations due to the Delta variant that is driving the third wave in the country. The Delta variant is a version of the coronavirus that has been found in more than 80 countries around the world. This is since it was first detected in India. It got its name from the World Health Organization, which names notable variants after letters of the Greek alphabet. So how bad will this variant get? For more on this, I'm joined by Dr. Daniel Israel, a general practitioner. Dr. Israel, a very warm welcome to your Daytime Update. Thank you for your time. Perhaps let's start with the differentiators. What makes the Delta variant different from the Beta, for example, which was at first dominant in South Africa?
So thanks for having me, Thami. The Beta in South Africa was the first variant that was picked up on our shores. And the differences between this and the Delta variant, which, as we know, originated from India, is that the Delta variant has shown to be more transmissible, not necessarily more serious, but more transmissible, which means that if you extrapolate that across the population, when you get more people getting this infection with more ease, you're going to get, at the same complication rate, you're going to get more deaths and, a worse clinical picture.
So talk to us then about, you say it's not necessarily more severe, but you've also just said that it would lead to more deaths. Explain that to us.
Okay, so just to give it clarity, we don't know 100% about whether this the clinical picture, but we have seen a very similar clinical picture to that with the Beta variant. However, the point that I'm making is that if you look at a 2% mortality rate or a 10% admission rate, but we know that this variant is going to spread much quicker and is going to be easily spread between people, 2% on 1,000 people is fewer patients than 2% on 10,000 people. So as people catch this more, it puts an increasing overload on the healthcare system.
There's also a phrase, Dr. Israel, that is used in your quarters, which is the reproductive number when it comes to these variants. Explain that to us and how it works.
Okay, so the R number of the virus is the number of people who are likely to be infected by one person if exposed without intervention. So we know, for example, that certain viruses, say measles, has got a much higher R value than COVID-19. And we were looking at R numbers of around 2 to 3 on the Beta variant. It has been brought forth on the new research with the Delta variant that the R number is actually higher. And that, this means that it's really more contagious and one person is more likely to spread it to more than 2 people as compared to the previous variant, which we saw in January this year.
I'd like us, Dr. Israel, to perhaps go back to the basics as to what impact the coronavirus actually has on the human body, whether we're talking the Beta, the Delta, or the Alpha, or any other variant.
So we know, Thami, originally we thought when COVID-19 started that this was purely a respiratory virus. We have learned over time that it really is a multi-organ virus. We know that in COVID you get a viremic phase, which is at the beginning when patients are just infected and have flu. And then a smaller percentage of patients go to a pneumonic phase where they then get involvement of the lungs and pneumonia. And everybody talks about COVID pneumonia all the time. Then there's also a cytokine phase, which is an even smaller percentage of patients. But this is when the inflammatory proteins that are caused by an infection circulate the body and really, like in layman's term, wreak havoc and cause massive inflammation in the body. So we know that with all these different phases, if someone does get complicated COVID-19, they are at risk of having, inflammation in their different organs and even clots as an increased complication.
Talk to us, Doctor, about the type of symptoms that we're seeing earlier on in COVID-19. It became quite prevalent that you can identify the symptoms of COVID-19. But more and more now, at least we're hearing of people who don't necessarily exhibit all of the symptoms. They are perhaps asymptomatic, but they reach their demise within a few days of saying that they're not feeling well. And upon a post-mortem, etc., the reports say that it was COVID-19. Talk to us about that, the fact that at times we are starting to see even less and less of the symptoms actually being displayed.
So we've always known that there's a percentage of people who are asymptomatic carriers or asymptomatic infected people who can then pass it on. We still continue to see that. I mean, one of the things that I think is a very important difference to highlight here is that patients in this wave are presenting with sore throats and congestion, and those can perhaps be their primary symptoms compared to, if you remember the beginning of last year, where a COVID-19 patient was a patient who had a dry cough, no taste, no smell. So we're seeing a much closer picture to the normal colds and flus out there, which makes it very difficult clinically. What you're referring to as well, though, is that because patients sometimes are copers and they do well, they may be infected and their oxygen levels drop, and they aren't aware of their oxygen levels dropping. And over a few days, not necessarily instantly, and then by the time we reach them and we intervene, they're already in a very serious position. And we are seeing this happening with people who are coming into doctors' rooms and my colleagues' rooms with low saturations and aren't even aware of it. So that is correct.
Talk to us, Dr. Israel, about the experiences that you and your colleagues have had. You wrote an article saying that in 1 week you came across 20 cases of COVID-19. What are you seeing on the front end?
So to be honest, just to correct that, it was actually in a day, and we're seeing the same today. I mean, I must say that even my practice in northern Johannesburg, we have seen 20 positive cases or so today. Now, that doesn't mean that they all come into the rooms, which is something that's been the doctors are very thankful for, because people have grown the insight and the knowledge to know that they must contact their doctors telephonically or electronically before they just come into the room. So that's been good. But from a patient load perspective, certainly all my colleagues are dealing with an absolute overwhelmment of patients coming in or phoning in either sick or concerned that they're sick. And therefore, really doctors' rooms, both inpatients and outpatients, are drowning in numbers at the moment.
And what do you recommend to these patients? What do you tell them to do upon diagnosis?
So I think the most important thing is to contain this virus. So as the president said last night, 10 days of isolation is a non-negotiable. So anybody who thinks they have the virus, even before they've tested, should quarantine at home for 10 days. So that's the first bit of information, is around what to do with quarantine. There is good evidence that shows that the right vitamin regimens and having good levels of those vitamins help with a better recovery. So we encourage that regimen. We are not proponents of, and correctly so, of antibiotics and inappropriate, experimental drug use and cortisone use, and at the wrong times. So it's about discouraging the wrong medication. And then obviously about the patient needs to monitor him or herself very carefully. So then check in with us regularly. So if they do become complicated, we are able to intervene early and get them the appropriate oxygen or medicine that they need early.
It's clear from what you're saying, Dr. Israel, that self-medicating and self-diagnosis is never really a good idea, because you mentioned that one can actually take what you call the wrong medication. But you also talk about a vitamin regimen that you put the patients on. What is that vitamin regimen?
So again, if you ask 10 doctors what they would do for COVID, especially maybe 6 or 12 months ago, you'll get 10 different recipes. And that is a problem, because for the layman out there, it's difficult to know who to trust and who to ask. So I'm involved in a lot of the doctor education in Johannesburg or in South Africa. And based on what the studies have shown, our experts, intensivists and physicians have suggested a COVID vitamin regimen of zinc, vitamin C, vitamin D, niacin. So those are in essence, however one couples them, those are the vitamins that we use. We certainly don't look at, as I said, experimental drugs and, a whole lot of other supplements that people come in taking, which are probably inappropriate and might even, put a bigger load on their organs.
And what are your views on the use of ivermectin, which some doctors do prescribe, and which the courts have actually, given permission for them to in some instances?
Okay, so I didn't mention the name purposefully, but so with ivermectin at the moment, we know that internationally ivermectin is being looked at as a possible treatment for COVID. But one must remember that there are other drugs that have also been looked at. And if you remember clearly at the beginning, there was a whole campaign to use hydroxychloroquine and Zithromax together for COVID, which showed very poor clinical outcome. Now, there is very limited data that shows that ivermectin does anything for patients with COVID. The point of perhaps contention is to how much harm it causes. There are physicians who claim that it causes a lot of side effects and it's because it's experimental, we should be careful. And there are others who are saying, well, if you take it, take it. We don't know if it's going to do anything. So we certainly would not advocate that people take ivermectin on their own, but, with the understanding that it's a drug under experimentation, if it is used appropriately, the time will tell how effective it will be against COVID.
You do say it is a drug under experimentation, but in many ways, so are the vaccines, in as much as they have been tested, but there's still continuous testing and experimentation that's taking place with the vaccines. And talking about that, we know that AstraZeneca was the first one that was brought into South Africa. The beta variant basically threw a cat among the pigeons, so that particular vaccine was no longer suitable for South Africa. But where do we stand now as far as AstraZeneca is concerned, considering the fact that the Delta variant is now the dominating variant in the country, and the fact that it's actually AstraZeneca that is being used in India as one of the three main vaccinations?
So I think it's important to make the point that vaccines are not experimental, from the fact that, we have seen across large data that people who are vaccinated, just as a general principle, are much less likely to catch COVID and do much better if they do catch COVID. That said, just on your point on the different vaccines, studies have shown that, for example, the Pfizer vaccine, after one dose, there's a 33% reduction of catching it, and after two doses, an 88%, and that's on the Delta variant. However, you rightly said that you can still catch COVID if you've had a vaccine and spread it on, but your chances of getting sick from it are much less. Talking to your point about AstraZeneca, we definitely made the correct decision to not roll AstraZeneca out, or the beta variants, which showed a very poor response, to put it simply, to that vaccine. However, as you rightly so, the AstraZeneca vaccine is being used overseas where there's Delta variants, and studies have shown a lot of promise. So it's an almost optimistic approach that we could say that, if we now have this variant here, we may be able to consider AstraZeneca again. But again, that's a bit beyond, just what to do on the ground. We will need very limited, quick studies to try and prove that and then try and roll it out.
What then, Dr. Israel, does it mean for those who have been vaccinated with the Johnson & Johnson vaccine, which is found to be of minimal effect when it comes to the Delta variant? Where does that put the country's vaccination drive now?
So I must correct you that it hasn't been shown to be of minimal effect. There are not adequate studies out at the moment that show the exact percentages, but the general thought is that the Johnson & Johnson vaccine is effective against the Delta variant. There are also studies underway as to whether Pfizer and Johnson & Johnson mixed together might be even better, and that is something that we will definitely look at. But obviously, we have to consider the access and equality of everybody being able to get a vaccine. So it's certainly this new Delta variant on our shores does not diminish the effectiveness of the Johnson & Johnson vaccine, and at the moment it is considered still to be a good vaccine.
Would you explain why then, Dr. Israel, some medical quarters are saying that a booster shot is most likely to be necessary if one has been vaccinated using Johnson & Johnson?
Yeah, it's not because of the inadequacy of the vaccine. It's because we know that in virology, different immune priming events will give greater immunity. So the Johnson & Johnson was designed to be a one-shot vaccine, but there's certainly, we haven't had COVID, thankfully, in this world for long enough to know what the exact trajectory is. But there certainly is a feeling that a second shot of Johnson & Johnson or an mRNA vaccine like Pfizer may give an even better protection. But it's important for the listeners or viewers to understand that it does not mean that people who have had one shot of Johnson & Johnson do not get protection from that single shot.
Thank you very much, Dr. Daniel Israel, for putting all of that into perspective for us. Certainly a time of a lot of questions as we all try to understand what this new variant means, especially under the new lockdown level 4 and how we move forward as a country. Thank you very much for your time and your insight this afternoon.